Thank you very much, and welcome back to this next session. We'll go straight ahead, and our first speaker is Dr. Audrey Forson, who is a consultant respiratory physician with the Kolebu Teaching Hospital and senior lecturer, Department of Medicine, University of Ghana Medical School. She's going to talk on late diagnosis of lung cancer in resource-poor centers.
This lady presented to our neurologist, 77-year-old female who had completed a 6-month course of anticox and was smear-negative TB, had not really improved, and then presented with a hemiparesis. And so he saw her, and she came with a CT scan of the chest. So just a few comments. It's about the most important cause of cancer death in developed countries. In our part of the world, at least in the series land from West Africa, liver cancer seems to be the most important cause of death, at least in males. It has a high mortality, there's late diagnosis. That's one of the main causes. And rates are higher in men, but they are declining. That's just in the Western world. It's declining in men, seems to be still increasing in women. And then in the younger age groups, I think that's related to the main etiology behind it being cigarette smoking, and that is on the decline. I got these figures from a paper written by a pathologist, Dr. Uridu, and another colleague, looking at the cancer deaths from the results from autopsies done between the year 1991 and 2000. And lung cancer is not very high on the list. And they had a 3.9% relative frequency, and then the age standardized cancer ratio was 4.56. As we've had discussions this morning here, we think the cancer rate is going up. The lung cancer prevalence seems to be going up, but we need to have figures. We haven't actually got values to confirm it. But what we do know is that cigarette smoking, and it's the smoke that contains the carcinogens, and these are a lot of polycyclic aromatic hydrocarbons, and makes such a big difference that almost more than 90% of smoking, 90% of lung cancer is caused by smoking, and that is many years of smoking. In Ghana, we have these figures where for men it's 10.62, and for women it's 2.6. There was a former figure of 7% given, so it would appear that it may have increased, but I'm not sure. This was a 2010 report, and 7% was the previous 2009 figure. There's also the prevalence of environmental tobacco smoke or passive smoking. And in one study, it was the cause of 1/4 of the cases of lung cancer that they saw, usually spouses of men who smoke. We also have occupational carcinogens, and radon seems to be one they mention a lot, breakdown product from uranium, and so miners in particular, but then it's also found in the atmosphere, and asbestos, arsenic, there are several others, beryllium, and these have a synergistic effect with smoking. So smokers who are exposed to these carcinogens have an accelerated rate. Indoor pollution, is talk about radioactive organic compounds from indoor, using solid fuels. Air pollution, not a very high, it's not a very high figure as the underlying cause, but it's still there. So we have diesel emissions. Genetics, there's a lot of studying going on, and there are many more. I just mentioned these two. But there are many more genes that they have found. Some are protective, and some are increasing your risk. And so this KRAS oncogene is very high in patients with adenocarcinoma. Micronutrients are being investigated, more looking at the protective ones, like the beta-carotenes, but the studies have not really confirmed their role, and I think it's still ongoing. So as I mentioned, 90% of lung cancer cases are due to smoking. We are seeing a lot of lung cancer. I wouldn't say it's a lot of lung cancer, but many of the ones we are seeing haven't got significant smoking history. And so that is something we should be looking at. What are the other risk factors? And when you have a heavy smoking history, it acts it triggers your memory to think of lung cancer. But where there's not a smoking history, we tend to forget about the possibility of lung cancer. And I think we should be looking at things like occupational exposure, and then there's radon in the community. It's in our homes. I don't know about here, but they've done studies in the West. Older age group, race. They found that African American men and non-Hispanic white men had the most lung cancer, and of that, 50%. It was 50% higher in African Americans. So probably because of their smoking, but is there something to do with their race and genetics? In which case, we in Africa are also at risk. Also, this thing about this idea of fibrosis being a focus for the development of lung cancer, I think that is something we should be looking at a bit more. We have post-TB treatment fibrosis or rheumatoid lung, and these are cases that could later develop lung cancer. COPD is not so common in some of our countries, but it's also an important risk factor. So we have a diagnostic dilemma. My emphasis, being a pulmonologist, not a surgeon, is the diagnosis of lung cancer being mixed up with the diagnosis of TB. So a lot of our lung cancer, even though it may not be such a high prevalence, it is being missed because every cough with hemoptysis or without hemoptysis, with weight loss, we say it's TB. And we have a high prevalence of TB. The figures that the WHO quote are 106 per 100,000. But we actually see about 60 per 100,000 cases are reported. Whereas with lung cancer, this is an estimate from some of these studies several years ago of 5 per 100,000. I think we need to get our own figures. So patients with lung cancer are often misdiagnosed as pulmonary TB or other diagnoses. HIV co-infection being quite prevalent, you have Kaposi sarcoma. You can have other conditions like something else came to my mind, rheumatoid arthritis, rheumatoid lung. Some of these should not be mixed up with this diagnosis. Also carcinoid tumors. I'm just going through this classification. Let me not mix things up. I have two classifications, non-small cell lung cancer and also small cell lung cancer. Large cell carcinoma is actually the third of the non-small cell carcinomas. But I wanted to put it in this order because this is the frequency of presentation. That the commonest is adenocarcinoma, and then squamous cell carcinoma, and then small cell carcinoma. Okay, so large cell carcinoma is one of the subsets of the non-small cell carcinoma. It is not that common. And the squamous cell and the small cell carcinomas are the most directly linked to smoking. For those who never smoked, there's more of the adenocarcinoma and the bronchoalveolar carcinoma being a version of it. So I have a few pictures. I don't think I will take time now. So this is squamous cell carcinoma. I can just picture us saying, TB with cavitation. Okay, so this is this, and then we have adenocarcinoma, bronchoalveolar carcinoma, and this is a lymphangitis carcinomatosis from secondary meds, usually breast cancer or something else. So these can easily be diagnosed as TB. In developing countries, we don't think of lung cancer. We're not thinking enough about it. And then we have similar symptoms I've mentioned already. They have common risk factors like smoking. There's a lot of substance abuse in TB. Sorry, not in lung cancer, in TB. We don't have adequate infrastructure for bronchoscopy, mediastinoscopy. Some places, not even the CT guided biopsies are available. And VATS is something that is still not available in all countries. And then we don't have a test that will conclusively confirm smear-negative TB. So we have a lot of clinical judgments in the diagnosis of TB. So I've mentioned some of these things already. The things that might make you think about TB would maybe be their social status and all that, but I think it's a bit difficult. These signs like hoarseness, should be a red herring. You should kind of a red flag, sorry. Ptosis, but they are late signs. If you wait for these, that means that you've got a patient who you cannot help much. In the chest X-ray, the difference is they talk about in lung cancer, you have more of irregular margins, like a speculated one I showed you. They also have prominent hilar shadows. And if you have that, you tend to have it with hoarseness. You have a widened mediastinum. You can have nodules and atelectasis or unresolving consolidation. So these things can also occur with TB. Rib erosions, no, those are exclusively malignant, but then that's late malignancy. With the parenchymal disease, the upper lobe predilection, but I seem to find that a lot of our lung cancers are also upper lobe masses. And I think there are studies that have shown that they tend to be happen at the cariners, the primary cariners. Also, you tend to get fibrotic change with TB. So these are some TB X-rays. And this, one thing you say is for such a large mass, there's no loss of volume. So that will make it unlikely to be lung cancer. And also, it's not very homogeneous. You can see some air shadows. This is another patient with TB. You can see more air bronchograms in these X-rays than you would see with a tumor. This is the squamous cell carcinoma again. This is the cavity, and this is a hilar mass. So it could easily be mistaken for TB. The means of diagnosing it, I think we've mentioned the X-rays and the CT scans, which are universally available. We need to be looking out for lymph node involvement, being able to stage it, and the size, the presence of other masses. The PET scan is useful, it's useful for the solitary nodules, where there's increased uptake of radioactive glucose. For distant mets, you might want to go further to these other tests, MRIs and nuclear scans. But we also have to get tissue confirmation. You might think it looks like a malignancy, it may not be. So that's where we look at cytology. Cytology might bring out about 20% of cases. It's not a very high sensitivity test. We have fiber optic bronchoscopy, and it could be endobronchial tumors you can biopsy or transbronchial biopsy. And that is ideally with some kind of imaging. In one center, they had a mobile X-ray machine, or you can have fluoroscopy, because it helps to be targeted, to know exactly where you are going with your biopsy. Bronchoalveolar lavage is useful for diagnosing TB. You culture I'll try and quickly, yeah. And then for staging, you need to have a look. There's this thing where you have endoscopic ultrasound, which is said to be transesophageal. But as somebody mentioned earlier, you can have it also as part of under bronchoscopy. Mediastinoscopy I've mentioned, and I've mentioned the other things. And a good thing is that we have now more stains. In preparing for the bronchoscopy, I thought that I just mentioned that some of these things you would look for. You want to get your platelets right, your INR right, spirometry, lung volumes less than 1 liter, patient is high risk. ECG, you don't want any recent ischemic events. You want to have your X-ray and at least an X-ray, probably a CT scan ideally. And then to get your diagnosis of TB out of the way, sputum smears should be done whenever there's a possibility. And then recently we've got the Gene Expert, which is a rapid PCR test, and that allows us to, it has a higher sensitivity to further exclude TB. Other things like pleural aspirates, pleural biopsy, this could easily have been passed for malignancy. Fortunately, it was amenable to CT-guided biopsy, which is what we are using a lot of, and it turned out to be a tuberculoma. So it's not, you can't just use imaging to diagnose it. So if you don't have all these investigations, you don't have access to bronchoscopy or mediastinoscopy, what are your options? And it looks like you have to have a high index of suspicion and maybe do a trial of anti-TB drugs, but you must have reviews. We tend to forget the patients and send them off, and then maybe 4 months down the line, they are really ill, and it's too late. We should investigate them for TB and also look at the cytology. I think using cytology where it's available is useful. And should be referred from DOT centers for early CT scan. Anybody with a suspicious X-ray, possibility of a mass, should be referred. And I think that's what is not happening. They are treating them for TB, but not referring for further investigation. These are some of the references I use. Thank you very much.
Thank you, Dr. Forson, for your very enlightening presentation. Our next speaker is Dr. Ernest Ofosu-Appiah, who is a consultant anesthetist with the National Cardiothoracic Center in Accra. And he's going to talk to us on the practice of anesthesia for thoracic surgery, a review.
Thank you very much, Dr. Badu. My outline is there will be a brief introduction, and then we'll talk about preoperative assessments, and then we'll look at some of the techniques we use in isolating the lung, and then we'll talk a little bit about my pet topic, which is pain management, and then we'll conclude. Historically, thoracic surgeries created a lot of problems for the anesthetists because of inadequate ventilation, hypoxia, hypotension due to penduloft and mediastinal flaps. And this brought about the development of lung isolation techniques and the use of one lung ventilation. The other problem was the control of secretions and other stuff like blood, pus, and which could move from the pathologic lung into the good lung and soil it and spread the problem. The other challenge which still persists in our sub-region, and there is a study being done by yours truly, where we ask patients who are going for surgery, or those who have had surgery before, what was their worst experience? And about 30 to 35% of the people who responded said their main problem was pain. So what they dread going for another surgery is the pain that they are going to feel after they've been cut and stitched up. Now, the pre-op assessment starts with a good history, asking about the cough, how much the patient is coughing, the characteristics of the cough, and whether there is any blood in it. This is and then we go on to do a dyspnea or exercise tolerance score, and we grade the exercise tolerance based on the modified Medical Research Council scale for dyspnea, which starts from not troubled by dyspnea except on strenuous exercises, and goes all the way to patients being too breathless to leave the house, or even they become breathless when they are dressing or undressing. Now, the level of breathlessness will tell us how well or how bad a patient is going to be during the postoperative period. We also look out for wheezing, and if the patient is wheezing, then they have to be optimized. They're treated with various bronchodilators and others for the wheezing to stop before patient is put on the list. Also, patients who have chest tightness and pain has to be investigated and pain managed adequately. If the patient has a weight loss, then cancer diagnosis should be tolerated, and they stand a risk of severe hypoxia intraoperatively. We ask about cigarette smoking, and also you have to rule out that the patient has got congestive cardiac failure, so rule out any swelling of the leg, abdominal distension, cough, etc., etc. Patients who have had previous CVA stands a higher risk in the postoperative period. And also patients with perivascular diseases, as well as the patients with paraneoplastic syndrome. Presently, we have a patient on a ventilator with paraneoplastic syndrome whom we did the case a few weeks back, and we are finding difficulty getting him off the ventilator because he had myasthenic syndrome. Now, also, therapy is started at the pre-op stage. We start, as I said, we start bronchodilators, steroids, antibiotics. We also start chest physiotherapy, patients who are in poor shape. And then we also teach them how to use the incentive spirometer before the surgery itself. And examination, we usually focus on the airway and the ease of intubation, also auscultating the lungs to know where the pathology is. And patients who have polycythemia usually stands a high risk of developing thromboembolic phenomenon in the postoperative period, especially when they are bedridden. So such patients, you have to pay particular attention to the polycythemia. And then we rule out cyanosis and clubbing. And we do the matchstick test. We ask the patient to blow a match about 20 centimeters from the mouth. And if they're able to do that, then it means they have adequate reserve. We also do the breath holding test of Zabriskie, which when we ask the patient to take in a deep breath and hold for about 30 seconds. If they're able to do that, that tells us that patient has adequate reserves to withstand the postoperative period. And then also we do lung function test, and the FEV1, as we all know, will tell us whether the patient has got enough reserves for a pneumonectomy if the FEV1 in 1 second is more than 2 liters, or for a lobectomy if it's more than 1.5 liters. Now, investigations, usually by the time I go to see the patients, my surgeons and the residents have done all the investigations. So I review the full blood count, red blood cells, and kidney function, as well as fasting blood sugar. And the LFTs, what we are looking out for is the albumin levels. If the albumin levels are low, that is a bad prognostic sign, because the patient is not well enough. Unless, of course, if the patient is malnourished from the pathology itself. We also review the chest X-ray, CT scan, and once in a while we'll do an MRI. We routinely do ECGs, and then we do blood gases to see what the baseline gases are. Now, in the operating room, usually the induction is IV. So the commonly used ones are propofol with fentanyl, thiopentone if you want to do a rapid sequence induction. A tormidative patient is unstable, and sometimes we do co-induction with midazolam propofol. Patients with bronchopleural fistulae, large lung cysts, emphysematous bully, and foreign bodies, sometimes we will do an inhalational induction for them. And we use either halothane and sevoflurane. Now we have sevoflurane in our hospital, so we can use that. And some of the cases too, we just go ahead and use total intravenous anesthesia or targeted control of infusion of anesthetics. Now, lung isolation techniques. There are indications to that, and I've divided it into absolute and relative, or you can say anesthetic and surgical indications. Now, the anesthetic indications are when there's a risk of soiling between the cuff and the cords, the vocal cords. So you have tracheoesophageal fistula, patients with hemoptysis, bronchiectasis, lung abscesses, and empyema, where there's a risk of soiling. You want to isolate that lung very early in the after induction. And then also patients with gas leak between the cuff and the cords, like giant lung cysts, bronchopleural fistulae, bronchopleural cutaneous fistulae, tracheoesophageal fistulae, and the rest. You also want to use a double lumen tube to isolate the lung. And then the relative indications are for pulmonary surgeries, esophageal surgeries, where you want one lung collapse, so getting a surgical access it will be very easy for the surgeon and the assistants. Also for patients who are coming for anterior spine surgeries, great vessels, and thoracoscopic surgeries is an absolute indication actually for the use of double lumen tube. Because without double lumen tubes, you cannot do the procedure. So this is usually the double lumen tube we use. And unfortunately for us, they come in very large sizes. They come in very large sizes, so we have to innovate when it comes to doing pediatrics. And this is to tell you when the tube is adequately placed. And also we use both clinical and fiber optic means to confirm double lumen position. So this is a patient with a double lumen tube. Well, I can't see the light from here. Okay, so with the double lumen tube, and as you can see, the lung is nicely collapsed, so the surgeon is happy and is doing what they do best. Okay. Now, managing one lung ventilation, I was going to talk about the physiology, but I have only 4 minutes, so I'll jump these slides and then go on to talk about how do you manage hypoxia. Now, if the patient is hypoxic and you've isolated one lung, what you have to do is first is to increase the FiO2. If that does not work, then you introduce PEEP to the dependent lung and then CPAP to the non-dependent lung. And usually with the CPAP, the lung that was collapsed will inflate a bit, so you have to alert the surgeon so you know that is going to happen. And the CPAP, you can start with a low CPAP of about 5 centimeters of water and go up if need be. Now, if oxygenation is not satisfactory, then you need to consider pulmonary artery clamping. There are other means of isolating the lung apart from the use of double lumen tube, and you can use a modified suction catheter. You can use a Fogarty catheter. We also have univent endotracheal tubes, which you can use with a bronchial blocker in it, and it gives the chance for introducing CPAP into. So this is a Fogarty catheter that you can use to block the lung, and that's the univent. We can also use the ANS endotracheal blocker, where you have the tube, you introduce the tube with a fiber optic scope, and then you have an adapter so you can ventilate from the side port. And this was an 8-year-old child who had a blunt chest trauma and had a transaction of the right main bronchus. So actually you can see so we use the ANS bronchial blocker to block the right main bronchus so they can do the bronchial repair. Okay, and that is a 1-year-old child with large congenital emphysematous bullae, whom we had to isolate the lung by using a small endotracheal tube and then intubating the left lung so they could work on it. And then this is, I was doing a corrosive 48-year-old man who had ingested caustic soda, and he was talking to us and all during assessment. But when we induced him, then I realized that the airway and the esophagus look pretty much the same. You couldn't make it, you can't see so that's the laryngoscopy view. And you can't see epiglottis, there's no aortic noise, there are no vocal cords. So it was quite a difficult situation. So at that time, the only way we could identify the airway was to press on the chest. And when we pressed on the chest, we could see air bubble coming through the airway. And that was how we managed to identify the airway and intubate this man. This was after the surgery, and you can see that the pharyngoplasty has been done. So now he can swallow and eat. For video-assisted thoracoscopies, I would say it's a minimally invasive surgery, and one lung ventilation is absolutely necessary. Some of the problems we have post-op is with chest drains, blood loss, hypoxia, pulmonary edema, secondary to sometimes IV fluid overload, and then pain management. Usually we use multimodal approach with thoracic epidural with paracetamol and NSAIDs if it's not contraindicated. We also use thoracic epidural with paracetamol and morphine boluses, or we can give morphine infusion with paracetamol and NSAIDs. And for pneumonectomies, we usually do paravertebral blocks with paracetamol and morphine for breakthrough pain if NSAIDs is contraindicated, or morphine infusion with paracetamol and NSAIDs. And you can see the surgeon with a 2-key needle trying to locate the paravertebral space. Usually it's the surgeons who do the paravertebral insertion, and then we'll continue with the infusions. And in children, what we usually do is a single short caudal epidural with paracetamol and NSAIDs, or intercostal blocks with paracetamol and NSAIDs, or sometimes we just do a wound infiltration with the local anesthetic. So in conclusion, to give a good anesthesia for thoracic surgery, one needs a good knowledge of the thoracic anatomy and an in-depth understanding of the respiratory physiology, pharmacology, and medicine to manage these patients successfully. Thank you very much.
Thank you very much, Dr. Ofosu-Appiah, for a very interesting presentation.
Good afternoon. Mine is just a comment to Dr. Ofosu-Appiah. What you've just said is not different from what we see back in Zaria, Nigeria. We've found out that most of the patients, nearly 80 to 90% of those with bronchogenic carcinoma, and indeed other chronic lung conditions, have received antituberculous therapy once or twice, when it is indeed not tuberculosis. So it's not, it happens. And we're working on that. We hope to report it soon. Thank you.
Sorry, just wanted to ask, sorry, I forget the name, the presenter about the bronchial cancer. We know that many people feel that everything is TB is proven otherwise. In your series, was there any use of things like maybe VATS to diagnose these tuberculomas or lesions that might have otherwise not been tuberculosis? Then for the one lung anesthesia, I was wondering, you mentioned that you use either bronchoscopy or clinical means to determine tube placement. Do you combine both methods together, or do you use clinical means if you're unsure of the location on your bronchoscopy?
In our center, recently we have had some major problems, even medico-legally, because before I became a consultant, which was a few years ago, the rule was to treat all patients as tuberculosis patients. And we did a little study, which has not been published. We found that more than 80% or 90% of patients who are on anti-TB drugs have no clinical evidence by way of either sputum positive, they're not sputum positive, or any other direct evidence. They're all indirect evidence. And we have had, in fact, our cases of bronchogenic carcinomas have increased in the last last year alone, we are having maybe up to 3-4 cases every month. And that's because we have deployed something as simple as sputum cytology combined with bronchoscopy, and we do all the various things. In fact, we are in process of trying to put our data together to make some reports, because we have found out now, it seems as if our cases of bronchogenic carcinomas seem to even be higher, getting as high, if not higher, than carcinoma of the esophagus. And it's, so maybe sometimes it's the problem is underdiagnosis, and other times it's the problem is with the physicians who are consistently placing patients on anti-TB drugs. Like I said, it was a big medical legal problem because a patient came in from the US and he was on 6 months complete therapy for TB. It didn't make much improvement. They put him another course. It was only when he was in severe respiratory distress we were invited to see. And just sputum cytology gave out the adenocarcinoma before we did bronchoscopy. Unfortunately, we lost the patient because the patient was too ill for us to do any surgery at all.
As an anesthetic, how will you approach intubation in a patient, for instance, that has an injury, intraoperative injury in the membranous part of the trachea and the right main bronchus? Just the practical steps to adopt.
Okay, thank you very much. Because of time.
I tend to agree that it's a widespread problem where a lot of chronic lung disease, conditions are being treated as TB. And I think as a physician, it's for us, it's because we have a lot of reliance on clinical diagnosis of TB. Once you can't get a positive smear, one kind of looks at the X-ray and then goes on to treat. But if we had better TB diagnostics and we're using we have rapid culture by midgets, you have now additional tests like the gene expert I mentioned. They are not absolute. Their sensitivities are about 80%, but at least it's better than total reliance on clinical judgment. And a lot of our centers too don't have physicians. They have lower level healthcare workers who just go on without thinking of referral. Somebody asked about whether we have transbronchial biopsy. No, where I trained to do bronchoscopies, they were using portable X-ray machines because I think it's not very easy. When you do transbronchial blind, it's a high risk of pneumothorax. If you go too far and you bite into the pleura, you get a pneumothorax. So over here, we are not doing it. We don't have the imaging, and I'm not confident enough to just go blind. And so we are not doing it. So endobronchial masses, yes. And that is why we tend to rely a lot on the percutaneous CT-guided biopsy or the VATS. We do have a few cases who have VATS. VATS is expensive. That is the problem. And so if the patients can't afford to do an expensive procedure, we have to look at alternatives. Yeah, so and I agree with the gentleman from Benin. I think we are not using the simpler test. So the sputum cytology is because people are not thinking about it. So high index of suspicion is important, and maybe we need to talk more about lung cancer. We are missing it quite a lot. I try to look at our figures from our chest clinic TB unit, and a lot of the patients didn't have postmortems. But at least I can say in this year, up to now, I've seen about 4 cancers being treated as TB, just in this period. Thank you.
Thank you, Doctor.
Yeah, thank you for your question. With confirming tube placements, usually I'll use only clinical. The only time I will ask for a fiber optic scope is when I do a right-sided intubation, and I'm not quite sure whether I've mixed the apex or not. Then I will do a fiber optic scope to confirm that I can see the right apex orifice. It's only because, when I confirm clinically and patient is stable, I'm happy with that. Yeah. With the membrane side of the trachea injury during surgery, when that is detected, that is good, because sometimes these injuries go undetected. And the only time you can detect is post-op, when the patient starts developing subcutaneous emphysema. Then you start thinking about that. And there's a case report in, I think, the British Thoracic Society Journal, which happened in Scotland, where a child was ventilated in the ICU after a double lumen tube and had developed such an injury. And unfortunately, the child died, and then at autopsy, they found out that it was a tracheal injury due to a stilette in the endotracheal tube that was used to intubate this child. So now the recommendation is that immediately you go past the course, you take your stilette before you pass your tube down. Yes, if it is detected intra-op, you have to identify the leak first, where the leak is coming from. Then you put your finger there and see whether there are any further leak. If there's none, patient can be saturated you saturate the lungs with 100% oxygen, and then with that you can buy time and put a few stitches. If patient is desaturated, then you can put your finger back in there. So it needs a lot of teamwork between the anesthetist and the surgeon. And then re-inflate the lungs, fill it with 100% oxygen, and then you go ahead and do the repair. If that is not possible, then the best thing is to isolate the lung by use of either a Fogarty catheter if it's available, or you use any of the bronchial blockers I talked about.